These are some practice problems to help you assess your understanding of what we've covered in the course so far. The content covered mostly corresponds to what will be assessed on quizzes 2 and 3. And I'll post another video of practice problems later on to assess your understanding of the content that will be assessed on quizzes 3 and 4. A cohort study of gold miners was conducted to assess the health effects of exposure to arsenic, cadmium, mercury, and lead during gold mining. In 2024, 5 of 12,500 gold miners died from cancer. The cancer mortality rate in the general population in 2024 was 10 per 100,000. What was the cancer mortality rate among gold miners in 2024 per 100,000? For a cause-specific mortality rate, we divide the number of deaths from that cause by the estimated mid-year population and multiply by 100,000. 5 gold miners died of cancer during 2024, and there were 12,500 miners, which gives us a cancer mortality rate among the gold miners of 40 per 100,000. Use direct age adjustment using the total of the two populations as the standard population to calculate the age-adjusted cancer mortality rates for gold miners and the general population. Round your final answer to the nearest whole number. Remember that direct age adjustment is one of the techniques we talked about for standardizing the rates from two different populations to a common age structure. This allows you to make a comparison between the two populations. For direct age adjustment, you need to know the age-specific rates of both populations. First, we're going to create our standard population by adding the people in the population in each age group together to make our standard population. So we add the gold miners who are age 0 to 30 to the people in the general population from that age group to get our standard population for the 0 to 30 age group. We add gold miners who are 31 to 60 to people in the general population who are 31 to 60 to get our standard population of 31 to 60-year-olds, and do the same for our 61 and over population. And we add those up to get our total standard population. Next, we use the cancer mortality rate from the gold miners and multiply the rate for each age group by our standard population we just created. For the 31 to 60-year-olds, we multiply 20 by 50,000, then divide by 100,000 to get 10. For the 61 and over age group, we multiply 200 by 31,550, then divide by 100,000 to get 63.1. Then we use the cancer mortality rate from the general population and apply it to the standard population. So we multiply 3.3 by our 0 to 30-year-olds to get 1, and multiply 5 by our 50,000 31 to 60-year-olds to get 2.5. And we add them to find the total expected deaths in our standard population. So our age-adjusted rate for the gold miners is 73.1 divided by our total standard population to get 65. And using the general population rate, we divide 10.9 by 112,500 to get 10. It's important to remember that these are fictitious rates because the standard population doesn't actually exist anywhere. We come up with these rates in order to make a comparison between the two populations that isn't skewed by age differences in the two populations. Which of the following is an accurate interpretation of the adjusted cancer mortality rates from the previous slide? Cancer mortality in gold miners was higher than what was expected compared to the general population. We're comparing the rate of 65 to the rate of 10. So more gold miners are dying of cancer than what would be expected if they were members of the general population. An underground deposit of a previously unknown substance contaminates the groundwater used as a drinking water source for some residents of a village. It's unknown whether the substance will have any health effects or if it's safe to drink. Researchers enroll 100 people who are exposed to the substance and 200 people in the same village who get their drinking water from another source. The researchers interview each person about their health history, place of residence, place of work, and what they eat and drink at the start of the study. This study can best be described as a cohort study. It's not a case control study because it's the exposure that has already happened, not the disease or the outcome. For a cohort study, we have the exposed people and the unexposed people, and we follow both groups and monitor for the development of the disease or outcome of interest. The Arctic is warming 4 times faster than the rest of the planet. Traditional underground meat storage methods that have been used for centuries are being impacted by climate change. As the permafrost warms and cellars are exposed to extreme weather events such as flooding, microbial hazards including botulism and physical hazards including cellar collapse present public health hazards. A team conducts a cross-sectional survey to determine how many families in rural Alaska are still relying on traditional cold storage for meat in 2024. This data will help quantify the magnitude of the risk and will be included in grant applications if designing an intervention to upgrade rural families to food storage methods that will remain safe with the warming climate. Is this surveillance? No, this wouldn't be classified as surveillance because surveillance has to be an ongoing, regularly occurring activity, not a one-time project. Your grant to improve access to climate-resilient food storage methods gets funded. Your intervention involves meeting with families in their homes for in-depth discussions about food storage and providing information on how to prevent foodborne illness and injury. How would ethics factor into what incentive you should offer study participants to compensate for their time and for welcoming you into their home? If your grant includes funding to ship a free meat freezer to each household, would this be ethical? Probably not. Institutional review boards overseeing research are ultimately responsible for meeting the requirements of Title 45, Part 46 of the Code of Federal Regulations, but the researchers also have an obligation to make sure any incentives for participants don't cause undue influence that might compromise a person's ability to provide informed consent. Something like a freezer for a household has so much monetary value that people might feel like they have to participate in this research study so they don't miss out on the freezer. So that would be too large of an incentive. The health department is conducting a longitudinal cohort study using primarily qualitative data to understand the lived experience of Alaska Native people with long COVID. The research team is conducting interviews every 6 months to gain a deeper understanding of what it's like to live with long COVID within the cultural and social structure of the local community. Because the focus is on a particular tribe and local culture, the researchers don't plan to attempt to generalize their findings to other communities. The goal is to improve the quality of services provided to people with long COVID who access care from the tribal health organization and identify other social services that may improve quality of life for this group of individuals. The Tribal Council and Tribal Health Organization will meet every 6 months for the first 3 years and annually thereafter to discuss the results from each round of data collection and use the data to inform local program planning to serve the study participants. Is this research? This probably would not be considered research because the primary objective is not to create generalizable knowledge. Following the anthrax outbreak in reindeer discussed previously, the research team conducted a serosurvey to determine effectiveness of the anthrax vaccine in animals they immunized the year prior. They tested 913 blood specimens from reindeer vaccinated against anthrax and found that 814 had a protective antibody level. They reported this as a population protection level of 89%, with a 95% confidence interval of 87 to 91%. This is an example of which type of study? Cohort study is the best answer because in this example, the vaccination that they administered 1 year prior was the exposure, and then they followed the population of reindeer and then reassessed them for the outcome, which in this part of their study was a protective antibody level against anthrax. This question's a little tricky because that study also involved the actual anthrax outbreak, but specifically with the vaccination part of their study, a protective antibody level was the main outcome they were looking for. The reindeer were selected to be study subjects because they're the same animals the team vaccinated previously, so they were selected based on their exposure status. This is different from a cross-sectional study where exposure and outcome are assessed at the same time and members of the population are included regardless of their exposure or disease status. Jane was recently diagnosed with fibromyalgia. She's interested in how past environmental exposures may contribute to the risk of developing fibromyalgia, and she'd like to participate in a research study to help further the understanding of the disease. Which type of study on environmental exposures and the development of fibromyalgia is Jane most likely to be able to participate in? She could participate in a cross-sectional study. She also could obviously participate in a case control study. The reason why nested case control study is not a correct answer is because for a nested case control study, the case and the control are both from the bigger cohort study, and she wouldn't be eligible for a cohort study about the relationship between environmental exposures and the development of fibromyalgia because she's already developed the disease. The same is true of a case cohort study design. That design differs from nested case control in the way that controls are identified, but is also a sub-study within a larger cohort study. Cross-sectional studies use a sample of the population that includes people who have the disease, who are prevalent cases, so Jane might be included in such a study despite already having been diagnosed with fibromyalgia. A case control study found a strong association between male gender and malaria infection. The odds ratio was 1.8 with a 95% confidence interval of 1.2 to 2.0. You notice when reading the methods and discussion sections that the authors failed to account for outdoor occupation, which is more frequent among males in the country where the study was conducted. In this study, outdoor occupation was likely a confounder. Outdoor occupation occurs more often in males, and outdoor occupation leads to a higher risk of malaria infection, but it's not on the causal pathway. Being male does not increase your risk of malaria. In your textbook, she words the criteria for a variable to be a confounder as needing to cause the outcome, but rather than a true causal relationship, I think it's better to think about it as it has to be associated with. Because if we said that outdoor occupation caused someone to be male, that doesn't really make sense. But outdoor occupation is associated with male gender. If you think back to the examples I used in the lecture about this, similarly, it would be weird wording and somewhat confusing to say that high socioeconomic status causes men to wear silk ties. It would be better to word it as wearing silk ties is strongly associated with high socioeconomic status. So I wanted to bring this up just in case you were confused by that in the textbook. According to Skelly, DeTore, and Brott, in addition to most other sources, although a confounding variable may be causative, it doesn't have to be. The primary requirements are that an independent relationship between the variable and outcome exists, and the variable isn't the result of the exposure or the result of the outcome. I'll include their article below these practice problems as an additional resource to clear up any confusion that might have been caused by the textbook's description of confounding variables. You volunteer to provide public health assistance in the Federal District of Brazil, which is in the midst of an unprecedented dengue outbreak with a prevalence of 14%. When you arrive in Brazil, the team lead explains the magnitude of the dengue outbreak to you by providing the number of new cases of dengue that occurred in the past month divided by the local population at risk. This measure is an example of cumulative incidence, which is a proportion. It's the number of new cases in a population during a specified time period divided by the number of people at risk for that disease during that time period. Remember that incidence rate has person time, usually person years in the denominator, and prevalence is the number of cases present in the population at a specified time divided by the number of people in the population at that time. Prevalence looks at existing cases, not specifically new cases. To better understand factors that lead some people to be at higher risk of dengue than others, a case control study was completed. The researchers reported a relative risk of 1.4 for dengue among residents of the federal district employed in the agricultural sector. What's wrong with this? You should never directly report a relative risk for a case control study. Odds ratio is the estimate of relative risk used for case control studies. The researchers shouldn't have claimed to have determined a relative risk based on their case control study. Remember that odds ratio provides a good estimate of relative risk for conditions that are rare, but it will exaggerate the difference for more common conditions. Which of the following is a type of bias? Loss to follow-up bias, also known as attrition bias or dropout bias, occurs when there's a differential loss of participants during the course of a study, leading to a non-representative sample. This can distort the observed associations between the exposure and the outcome if the reasons for people dropping out are related to the outcome of interest. While some sources classify confounding as a type of bias, it's usually considered a separate entity, so loss to follow-up is the best answer. Cystic fibrosis is a genetic disease caused by a defect in the transmembrane conductance regulator protein, which moves chloride to the cell's surface. This mutation causes mucus in the lungs, pancreas, and other organs to become thick and sticky, so the body can't clear it effectively. Mucus buildup leads to an environment for bacteria to grow, increasing the risk of pneumonia. If someone has 2 copies of the defective gene, they will have cystic fibrosis. A person with 1 defective copy and 1 normal copy of the gene will not have the disease, but will be a carrier. If 2 people who are carriers have a child, the odds their baby will have cystic fibrosis are 25% that the baby will have cystic fibrosis, 50% the baby will be a carrier but not have the disease, and 25% the baby will not be a carrier or have the disease. The defective gene is blank to cause cystic fibrosis. Necessary but not sufficient. You need a copy of the defective gene to have cystic fibrosis, but if you only have 1 copy, you won't have the disease, you'll be a carrier. No one who doesn't have a defective copy of the gene can develop cystic fibrosis. 2 copies of the defective gene are necessary to cause cystic fibrosis. A randomized clinical trial is being conducted to assess the efficacy of a new cystic fibrosis treatment. 1,000 patients are enrolled and randomized to either receive the new treatment or the standard treatment. During the study, the principal investigator reads that preterm infants with cystic fibrosis have a greater chance of premature mortality. He disqualifies 12 of 500 patients receiving the new treatment, given this new information, because he's concerned the patients who are born prematurely may minimize the effect of the new treatment if they have worse clinical outcomes due to their pre-existing condition. Were the investigators' actions justified? Why or why not? The investigators should not have excluded participants after randomization based on the treatment group they were assigned to, because this introduces exclusion bias and will compromise the internal validity of the study. Remember that exclusion bias is a type of selection bias that occurs when subgroups of people are intentionally excluded from the sample after randomization, leading to a systematic difference between the treatment and control groups. Exclusion bias can also be a problem in case control studies if people with a very high or very low rate of prior exposure are excluded from being either cases or controls, but not excluded from both groups equally. A clinical trial for a new cancer treatment enrolls 129 patients. At the end of the trial, 47 patients have died. The researchers report the risk of death for study participants was 36%, and the odds of death was 57%. What's your interpretation of this? The researchers are misreporting the data because the risk of death and odds of death should be similar since the incidence of cancer is less than 10%. Or this makes sense because the risk of death includes all study participants in the denominator because all the patients were at risk of death, but odds only has the survivors in the denominator. Here's the difference between risk of death and odds of death for this example. Risk of death is the 47 patients who died out of all the patients who were at risk of death during the study, 129, for a risk of 36%, while the odds of death is the 47 patients who died divided by the patients who did not die, the survivors. We find the survivors by subtracting the 47 people who died from the 129 patients to get 82. So the odds of death was 57%. You're reading about a case control study that enrolled 10,000 women with pelvic inflammatory disease and 10,000 women without pelvic inflammatory disease as controls. The researchers were interested in learning more about the effects of sexually transmitted infections such as gonorrhea and chlamydia on the long-term risks of pelvic inflammatory disease. Which measure or measures of association can be calculated from this type of study? Relative risk, odds ratio, risk ratio, or rate ratio? Odds ratio. The other measures can't be calculated from a case control study because you don't know the incidence in the population. You're enrolling 10,000 women already diagnosed with pelvic inflammatory disease and 10,000 women without pelvic inflammatory disease. So you're making an artificial population with a prevalence of 50%. You can't then use the incidence of 50% in calculations of risk. That wouldn't make any sense. But when a condition is uncommon, the odds ratio provides a good approximation of the relative risk or risk ratio. In survival analysis, such as when the treatment and control arms of a clinical trial are being compared, the blank summarizes the difference between the two groups with a single number, which indicates no difference if it's equal to 1. The probability that the difference between the two groups is due to chance is calculated using regression models and reported with a 95% confidence interval and a p-value. Is the blank risk ratio, rate ratio, odds ratio, or hazard ratio? Hazard ratio. Remember that hazard ratio is like odds ratio, but instead of being for a specified time period, it's the chance of the outcome over the course of the study. Hazard ratio is the hazard in the exposed group divided by the hazard in the unexposed group. Which of the following explains the trends in disease X in the United States population? More cases of disease X are being diagnosed, but are being caught at an early stage when a curative treatment is effective, so new cases aren't developing into chronic disease. There's an increase in the number of cases with the increase in diagnosis, but the duration of disease is short because those new cases are getting cured. This would explain the incidence of a disease increasing without a corresponding increase in the prevalence within the population. Blank surveillance involves public health agency staff periodically gathering data from sources such as hospitals and laboratories, while blank surveillance relies on healthcare providers to report cases on their own initiative. In active surveillance, the public health agency initiates collection of data from labs, healthcare providers, or the public, such as by making phone calls or going to hospitals and doing chart reviews. While in passive surveillance, data is generated without solicitation by a public health agency, such as continuous reporting of certain notifiable infectious diseases to health departments at the time of diagnosis by clinicians. Passive surveillance systems will miss cases. This is an expected downside because you're not paying the clinicians or members of the public to report cases and they have other things going on. But passive surveillance systems are much more cost effective. It takes a lot to have an active surveillance system where you often have a team of epidemiologists, including doctors, nurses, statisticians, and data management professionals all working together to be totally sure that no cases of that condition are missed. Public health agencies have to decide based on the specific condition whether an active surveillance system is warranted or whether a passive surveillance system will get the job done.